I'm Ako Nnochiri, a consultant gynaecologist who works here at the London Independent Hospital. I tend to see patients who come to me with all sorts of problems. Commonly, what we tend to find are patients who have painful bleeding, or their bleeding is much heavier than they can cope with, which can make them very tired. It could also be that they've got pelvic pain, which has been going on for a while, and they've gone to see their GPs and who would have done some investigations but not been able to get to the bottom of what's going on. And this sort of patients are now referred to see a specialist to try and get to the bottom of what may be the cause for the symptoms that they present with. And some of these symptoms, especially with something like endometriosis, could be something that young lady may have had from when they started having their periods. They tend to start with heavy, painful periods. Usually we tend to say it will go away as time goes on, but some of them just don't. And this pain can start before the period actually starts, a few days, and sometimes can last all through the periods, and they can be quite incapacitating. They may sometimes radiate to the back, they go all the way to the back of the patient, and can sometimes go down the upper thighs and maybe down to the legs. You would have been given so many other, painkillers, things to try and take care of this pain, but it still happens. And it tends to happen, like I said, every period, and gets worse as the years go on. And in the main, I think we know that it can take up to 7 to 8 years sometimes to make a proper diagnosis of endometriosis. And that is when we'd expect that if you have tried simple painkillers, and some GPs will probably put you on some contraceptive pills. And if this hasn't really helped your symptoms, or you find that this pain is probably getting you down, then I think it's time for you to ask to be sent to somebody who could actually do a few more investigations to try to get to the bottom of what's going on. The other thing that, one of the other things that patients come to see me for, again, it could be heavy bleeding on its own, not necessarily the pain, but they tend to pass loads of clot. They're quite tired because they've lost a lot of blood. And sometimes they may actually feel there's a bit of a lump within the lower abdomen. And that could just be the first signs that you get, or that you may have a fibroid, which is a small mass that grows within the womb and can get very, very big to cause heavy bleeding. The GP may well have given you some painkillers, given you something, some medication to try and reduce the amount of bleeding, may well have started you on some contraceptive pills. But if it's not going away, or you find yourself bleeding in between periods, then you may also want to see a specialist. And when you come to see me, I would want to investigate this further. Of course, I would talk a little bit about your problems. I would ask how long it's been, whether you have, how long this pain has been, how you're coping with it, what you've try to get to the bottom of what has gone on before you come to see me. And we would do physical examination to try and see whether there are any lumps and bumps in the pelvis, to see where in particular this pain is located, because sometimes it can be localized to one side of the lower abdomen or the other. We may need to see whether your womb is fixed, because it's stuck to things, which we call adhesions, that can happen in endometriosis, or that the womb is just bigger because you've got fibroids. After that, I usually would send you for a scan, which you may well have done with your GP. With regards to endometriosis in particular, most times when you've done all these investigations, they don't really come up with anything. And I tend to see patients, or hear patients say, I've done everything. They told me I don't have any endometriosis. A normal investigation cannot rule out endometriosis. The only way to make a diagnosis of endometriosis will be to put a camera through the belly button sometimes, have a look inside to see whether there is endometriosis or not. So the fact that you've had various investigations and hasn't really shown anything doesn't necessarily mean you don't have it. Your symptoms are probably, the kind of symptoms you have will probably point towards the diagnosis more than the investigations. But of course, investigations can throw up certain things like an ovarian cyst, which can be common in endometriosis. It could show that some of the structures within the lower abdomen in the pelvis may well have moved in certain directions or pulled in one direction because of the scarring from endometriosis. And these are things that we can find and then go ahead to plan how best to manage you. With regards to fibroids, the same thing as well. Of course, that one we would see something when we do a scan. It will tell us that there are some lumps within the womb. And it's very important to know where these lumps are located within the womb, because there are some fibroids that would be within the muscle of the womb, some will be on the outside of the womb, and then some will be within the cavity inside the womb itself. And those ones are the ones that actually cause most of the heavy bleeding. And also the number of where they are or how big they are would also determine how we would approach managing you. When it comes to treating these conditions, the fact that you're coming to a gynecologist doesn't mean that you're going to have surgery. There are other ways in which we can manage them. And sometimes we hope that your GP would have tried some of these in the past. And all we can do is try to reinforce that and maybe tell you a different way to try and take the medication. It could just be something as simple as painkillers, because fibroids or endometriosis can present with pain. It could be hormonal treatment, something like the contraceptive pill, either the combined pill for those that can take it or the progesterone-only pills. And of course, these have their own side effects, but they do help with the symptoms. And that may be all that you need to manage your condition, as it were. And of course, we have different categories of patients. We got the ones that, depending on what your needs are, some people, it's because they're trying to get pregnant. We would manage them differently because obviously in those patients, a hormonal treatment may not be the best because it goes against what you're trying to achieve. In such patients, probably surgery might be the best way to approach that. And some other patients who fertility is not what they're after, but just to manage the symptoms, we can manage them medically by way of giving them the contraceptive pills or painkillers. Sometimes we have some injections that can completely stop the periods, but of course these injections will also bring up symptoms as if you've gone through menopause with hot flushes and irritability, not being able to sleep. And some patients are able to cope with that or not, but it does significantly shrink the fibroids. But I think I've got to point out that that's temporary, because once you stop the medication, which we would not usually give you more than 6 months to a year, then your fibroids can grow back to what they were before. So those kind of managements could be because you need it for a short time, or we're giving you that just before we do surgery to try and reduce the size of the fibroid if it was big. And therefore, after we've done that, we would now decide what sort of surgery, if that's the path we want to go. For me, in particular, most of the cases that I do with fibroids, I tend to do them through keyhole, but of course that would depend on where the fibroid is, the number, the size, because patients tend to recover much quicker after keyhole surgery. And of course, as I mentioned earlier with endometriosis, the only way to make a diagnosis will be to do your keyhole surgery, have a look in the pelvis, see where the scar tissues are, see where the endometriosis is, and try to excise that, which is cut it out. But it doesn't just end there when you do that. You would, for me, I always like to get patients to understand how to manage their endometriosis going forward, because there's really no cure for endometriosis. Rather, you take out the scar tissue that's there that's causing the pain, and then you try to prevent more endometriosis from building up. And that may well be that you get pregnant if that's what you want to do, if you're able to do that, and that would also help to suppress your endometriosis. But after you've had your baby, it will be important for you to try some sort of hormonal suppression or any other tablets that you think may work for you. You think may work for you with regards to managing and suppressing the endometriosis long term, because it's only when you get to menopause that your ovaries stop working and producing the estrogen that feeds your endometriosis, which is why it's very, very important that you suppress them after surgery. Otherwise, what tends to happen is that I'm sure you've heard stories about people coming every year and a half or every 2 years to have the same surgery, and that is because nothing has been done to try and prevent the endometriosis from coming back. And when it comes to fibroids, I always like to counsel patients and let them know that fibroids can grow back. Not the ones you've cut out, but every muscle within the womb can become a fibroid. And therefore, for people who are prone to having fibroids, they should know that it is possible that other fibroids can grow. But if you've really taking away all the fibroids that are there, what you're actually doing is giving that lady a window of probably about 5 to 8 years where they could use that if they wanted to try for a baby at a time, or just to reduce the symptoms if that's what it is. And of course, if they have completed their family, then you would need to consider other options, which could be what you call uterine fibroid embolization, where we don't do that as gynecologists, the radiologists do. They tend to find the blood supply to the fibroids and block these blood supplies, and over time the fibroids will shrink. It is very effective in helping your symptoms and also reducing the size of the fibroids. But if you've completed your family and you do not feel that you need your womb anymore, then we could do what you call a hysterectomy to try and completely remove the womb, so there is no chance of any other fibroid. I could spend all day trying to tell you about these conditions and what we could do to help you. But of course, it would be much better if you are able to book an appointment to see us if you're having such symptoms, and so we could sit down and have a chat with you and try to tease out what the problems are and see how best we can help you.